Good morning. I hope you are all doing well. This is Dr. Ziad Salim. I will be starting the first lecture of this series about hematopoiesis. As you may know, hematopoiesis is a process of blood cell formation, and this includes erythropoiesis, myelopoiesis, thrombopoiesis, and lymphopoiesis. The hemapoiesis or hematopoiesis starts in the fetus in the first 2 months in the yolk sac, then it moves to the liver and spleen, and finally, at the end of gestation, it moves to the bone marrow. In infants, hematopoiesis occurs in the bone marrow, essentially in all bones. However, in adults, hematopoiesis occurs in the central parts of the skeleton, that is the vertebra, ribs, sternum, skull, sacrum, and pelvis, and in the proximal ends of the long bones. This diagram shows the hematopoiesis as it occurs in the yolk sac, liver, and spleen in the fetus, and then moves to the bone marrow. Meanwhile, there is also conversion of hemoglobin synthesis, eventually producing the alpha-2 beta-2, which is the adult hemoglobin. There's some amount of alpha-2 gamma-2 and alpha-2 delta-2, which are present in small amounts in the adult. In infancy, all the marrow space is hematopoietic. However, as there is remodeling of bone, as the child grows from infancy to childhood to adulthood, there is more bone marrow space than is needed for the hematopoietic elements, and therefore there is progressive fatty replacement of the marrow throughout the long bones. And in the adult, hemopoietic marrow is confined to the central skeleton and to the proximal ends of the femora and humeri. And even here, only 50% of the marrow consists of hemopoietic elements, and the rest is consisting of fat. We should always remember that the bone marrow fat may decrease when there is excessive requirements for hematopoiesis in various types of diseases, such as the patients who have hemolytic anemia. There is expansion of hemopoietic elements in the bone marrow, and this may expand the bone marrow space. Fat spaces become minimal, and in certain pathologic conditions, such as in certain myeloproliferative disorders and in major hemolytic anemias, congenital types such as thalassemia, hematopoiesis may revert to the liver and spleen. And as you can see here in this picture, this is a child with thalassemia major who has a huge spleen, and if you remove that spleen and examine it, you find that there is hemopoietic elements in it. We examine the bone marrow by either taking an aspirate from the bone marrow cavity, or we can use a larger caliber needle to take a core. You can see it here on the right side. This is called a Jamshidi needle. We use it to take a core of the bone marrow, and we can examine the bone marrow aspirate and the bone marrow biopsy, or called trifine biopsy, to look at the structure of the bone marrow. The aspiration can be taken from different sites. For example, mostly taken in the adults from the posterior iliac crest, although it can be taken from the sternum in the adult, and from the tibia in infants. The trifine or core biopsy is always taken from the posterior iliac crest. We can use special stains to look at the bone marrow elements. Use the Wright-Giemsa or Romanowski stain for the aspirate, and hematoxylin they use for the bone marrow core biopsy. We can use the aspirate for doing excess or extra studies such as flow cytometry, cytogenetics, molecular tests such as FISH, DNA or RNA analysis for gene abnormalities, and sometimes we do a bone marrow aspirate to obtain cultures for brucellosis, for example, or tuberculosis. Here, this is a smear from a bone marrow shown grossly, and in the middle under low microscope, low magnification microscopy, and on the right on higher magnification. And we can identify the different types of cells in the bone marrow. This is a core biopsy or trephine biopsy. You can see the fat spaces. These are the white spaces, and during the fixation process, the fat is dissolved, and this is why you see the empty spaces. On the left side, there is a bone trabeculae, and between the fat spaces, you can see the different types of hemopoietic elements, including the large cells, and these are the megakaryocytes. This is the diagram that shows you that the hematopoiesis occurs around the sinuses. The fat cells, the endothelial cells line the sinuses, and the hemopoietic elements, as they mature, they are moved into the sinus, and from the sinus they go into the central vein and into the circulation. So all the developing cells are located outside the bone marrow sinuses, and mature cells are released into the sinus spaces, the microcirculation, and then into the general circulation. I just want to show you this diagram. This is how we started more than 40 years ago doing experiments on the bone marrow to see how the stem cells work. And if we take a syngeneic mouse, give it a lethal dose of radiation, 900 centigrade, and this will damage the bone marrow cells. It does not damage the bone marrow microenvironment, just the bone marrow stem cells. If we do not rescue those mice with a bone marrow transplant, they die. However, what we do is we obtain bone marrow cells from a syngeneic mouse and inject them after suspending them into the tail vein of a irradiated mouse, and then sacrifice this mouse around 8 to 12 days later and examine the spleens. And if you look on the right side, you see that there are nodules in the spleen. These are colonies of hemopoietic cells that have been derived from the donor mouse, and they are composed of all the hemopoietic elements that you can see in the bone marrow. Just to note that the spleen is a hemopoietic organ in the adult mouse. So this is why the stem cells will home to the spleen and form those nodules, in addition homing to the bone marrow of the mouse. You can also, by doing mixing studies, confirm that all the colonies are formed of a single clone of cell, so they are clonal. If you mix stem cells or bone marrow cells from a donor mouse that is X, and together with donor cells that are Y, that's male and female bone marrow cells, and inject them into the tail vein, you will find that the colonies will be either XY or XX. We can also culture the stem cells of the bone marrow in the Petri dish. We can use agar, soft agar, together with nutrients, including plasma from fetal bovine sources, together with various types of growth factors, and we get colonies that can grow in the agar, and we can examine them to see what are the growth factors that will influence the growth of those colonies. There is a common pluripotential stem cell which undergoes a certain number of divisions and differentiation. And this eventually gives rise to a series of progenitor cells for the three main marrow lines. These are the erythroid, granulocytic and monocytic, and the megakaryocytic series, in addition to the common lymphoid stem cells. The stem cell also has the capability of self-renewal, as well as differentiation and development. The precursor cells have the ability to respond to hemopoietic growth factors with increased production of one or more cell lines when need arises. There is a built-in amplification in such a way that one stem cell can give up to 1 million mature blood cells after 20 divisions. The bone marrow is also the primary site of origin of lymphocytes in humans. There's evidence for a common precursor cell for both the myeloid and lymphoid cells. This diagram shows the stem cell. It can proliferate and regenerate, there's self-renewal, and it can progress and mature to develop the progenitor cells that are recognized by culture techniques. And those progenitor cells that are not recognized morphologically will eventually lead to the production of the bone marrow elements that we can recognize by microscopy. These again will proliferate eventually to produce the mature cells. As self-renewal decreases with this process, there is progression in the direction of differentiation and maturation. This diagram shows the pluripotent stem cell on the top, leads to the lymphoid stem cell, which leads to the production of lymphocytes, B, T, and NK cells. And again, it can also produce the myeloid progenitor, mixed myeloid progenitor cell, CFU GEMM, which produces the burst-forming units, erythroid, which eventually produce the mature red cells, the megakaryocytic progenitor cells, and the myeloid cells, the monocytes, neutrophils, eosinophils, and the basophils. The bone marrow stroma is essential for hematopoiesis. Bone marrow forms a suitable microenvironment for stem cell growth and development, and it's composed of stromal cells and microvascular network. There is specific recognition and adhesion sites, extracellular glycoproteins, and other compounds that play a role in the cascade of events. If we damage the bone marrow microenvironment, like for example, if we subject the bone marrow to high dose of radiation, this will damage not only the stem cells, but also the microenvironment. So this site in the bone marrow will not be hospitable to any growth of the hemopoietic elements. This diagram shows the interaction of the stem cell with the macrophage, the fibroblasts, fat cells, and the extracellular matrix. And this interaction together with the growth factors results in the proliferation of the stem cells. If hemopoietic stem cells are infused intravenously into a suitably prepared recipient, they circulate and they will seed in the marrow successfully, but they do not seed other sites. This is the basis of bone marrow transplantation. A mature cell is one that has differentiated to the stage at which it has the capability of carrying out all its specific functions. Each blood cell has a finite life cycle and finite lifespan. And the cell is a component of the peripheral blood only during part of the life cycle. In the adult human being, RBCs, granulocytes, monocytes, and platelets are found in the bone marrow. Lymphocytes, however, are found both in the marrow and in the lymphatic tissues, including the spleen. Here, this diagram shows the lifespan in the circulation of different blood elements. The red cells survive 120 days, platelets 10 days, neutrophils only 6 to 10 hours, monocytes 20 to 40 hours, eosinophils and basophils survive for days, and lymphocytes weeks or years. The basic process in maturation of red blood cells is the synthesis of hemoglobin and the formation of an enucleated biconcave small corpuscle, which we call the erythrocyte or mature red blood cell. The cellular changes that occur during RBC maturation include decrease in cell size, condensation of nuclear chromatin, decrease in nuclear diameter, accumulation of hemoglobin in the cytoplasm, referred to under the microscope as eosinophilia, decline in the number of ribosomes, which is a decrease in the amount of basophilia in the red cell, and eventually the ejection of the nucleus. These are the recognizable elements in the erythroid series in the bone marrow and the circulation. The proerythroblast is the earliest recognizable erythroid precursors. This divides and results in the formation of what we call basophilic erythroblast, then polychromatic erythroblast, pycnotic erythroblast, reticulocyte, and eventually the mature red cell. One pronormoblast undergoes multiple divisions will result in the formation of 16 mature red cells. All the nucleated elements are in the bone marrow. They don't circulate normally. The only cells that circulate are the reticulocytes and the mature red cells. And there is no mitotic activity beyond the late or pycnotic cell stage. How do the normoblast, reticulocytes, and mature RBC differ? The normoblast contains nuclear DNA, RNA is present in the bone marrow but not in the blood. The reticulocyte does not contain DNA but contains RNA, small amounts. It's present in the bone marrow and present in the circulation, in the blood. The mature red blood cell does not contain neither DNA nor RNA, but it can be seen in the bone marrow and in the peripheral circulation. This is from histology. You know that the mature red cell is a biconcave disc, 7.5 micra in diameter and 2 micra in width, and it's malleable. This shape gives it the ability to transverse small capillaries that are smaller than its size, such as going through the sinusoids of the spleen. As you know, the normal hemoglobins in the adult is predominantly hemoglobin A, which is alpha 2 beta 2. There is a small amount of hemoglobin F, which is alpha 2 delta 2, alpha 2 gamma 2, and hemoglobin A2, which is alpha 2 delta 2. The hematopoietic growth factors are essential for the bone marrow to function normally. These are glycoprotein hormones that regulate proliferation and differentiation of the hemopoietic progenital cells and the formation of mature blood cells. They may act locally at the site of production or they circulate in the plasma. Common features of those hemopoietic growth factors is that they are glycoprotein that act at low concentration, act hierarchically, are produced by many cell types, affect more than one lineage. They usually are active on progenitors and functional end cells, and again usually show synergistic interactions with other growth factors. They may act on neoplastic equivalent of the normal cells and have multiple actions, such as they influence proliferation, differentiation, maturation, and membrane integrity. Erythropoietin is one of those growth factors. It's a glycosylated protein produced primarily by the peritubular interstitial cells of the kidney. It's also produced in smaller amounts in the liver. Its production in the kidney is produced by low oxygen tension, and it stimulates erythropoiesis by increasing the number of progenitor cells that are committed to erythropoiesis. The erythropoietin is produced, as I said, by the interstitial cells of the kidney. They act on erythropoietin. They act on the late BFUE and CFUE and on the early erythroid precursors in the bone marrow. The production of erythropoietin is under the influence of the factors that affect the oxygen tension in the kidney, and these are atmospheric oxygen tension, oxygen hemoglobin dissociation curve, cardiopulmonary function, hemoglobin concentration, and renal circulation. The erythropoietin level is markedly increased as the anemia becomes more severe, and the more severe the anemia, the higher the erythropoietin level tends to be, except in patients who have renal failure or who are anaphoric. In spite of anemia, their erythropoietin level remains low. Because the mature red cell, has a finite lifespan of around 120 days, red cells are being destroyed every day in large numbers, and large numbers of new red cells have to be produced to replace the cells that become senescent and die. Around 10 to the 12 erythrocytes are produced each day, and as we said before, the reticulocytes contain RNA, and they circulate for 1 to 2 days before they mature and they lose their RNA. Those reticulocytes are larger than the mature red blood cells. They stain with methylene blue, and on right Giemsa stain they look polychromatophilic. And we always look at the reticulocyte count to have an idea about the activity of the bone marrow. We will come to the issue of absolute reticulocyte count later. These are reticulocytes stained with supravital stain, and you can see the RNA, especially in the cell at the top of the right side of the slide. And this is just a diagram to show the reticulocytes, how they appear, upper left side, right Giemsa stain, and on the right with the supravital stain, methylene blue. So erythropoietin is a true endocrine hormone that can increase RBC production by 5-fold. So if somebody is anemic, if for example somebody has hemolysis, that's destruction of red cells that continues, this anemia that results will result in stimulation of the bone marrow erythroid precursors to proliferate more, erythropoietin production is increased, and the bone marrow can compensate for this hemolysis by increasing its rate of red cell production by 5-fold. The reticulocyte, as we said before, contains the RNA, and It survives in the bone marrow for around 3 days, and 1 day in the 1 to 2 days in the circulation. So the reticulocyte is present in the bone marrow, and the total number of reticulocytes in the peripheral circulation represent around 50,000 per microliter. Sometimes we express the reticulocytes as percentage of the mature red cells by looking on the smear and find out how many reticulocytes there are and how many mature red cells. If there is 100 mature red cell and 1 reticulocyte, then we say the retic count is 1%. But as you can realize, this is a percentage. If the number of mature red cells decreases for any reason and the number of reticulocytes stays the same, then the percent reticulocyte will double. So if we want to have an idea about the activity of the bone marrow, how active is it, then we have to look at the absolute retic count, and we can have an idea about the absolute retic count by determining the percent reticulocytes and multiply by the patient's hematocrit and divide by the normal hematocrit for that patient, what that patient's hematocrit is supposed to be. This will give us the absolute reticulocyte count. And because the anemia, if it's severe, will result in earlier release of the reticulocytes under the influence of erythropoietin into the circulation. So instead of staying 3 days in the circulation, 3 days in the bone marrow and 1 day in the circulation, the reticulocyte may stay only 1 day or even less in the bone marrow and maybe 3 days in the circulation. So to have an idea about how active the bone marrow, then we have to do also further correction to determine the reticulocyte index, to get the reticulocyte index. If the anemia is severe, we have also to divide by the hematocrit. If the hematocrit, for example, is less than 20, then we have to divide the absolute reticulocyte count by 2.5, just to have an idea how active the bone marrow is. As you know, the normal function of hemoglobin and the red cells is to carry oxygen to the tissues. 1.3 millimeter of oxygen is carried per gram of hemoglobin, and only 25% of the oxygen is removed by the tissues. This can increase up to 60% in patients with anemia due to increase in the amount of 2,3 DPG. The oxygen hemoglobin dissociation curve is also important for the delivery of oxygen to the tissues. Acidosis increased 2,3 DPG, increased carbon dioxide, and hemoglobin S will shift the curve to the right, and this will make the oxygen delivery better to the tissues. However, alkalosis, hemoglobin F, decreased 2,3 DPG will shift the dissociation curve to the left, making the hemoglobin stingy and unable to deliver oxygen to the tissues. So acidosis, increased 2,3 DPG, CO2, and hemoglobin S will release the oxygen better to the tissues. When we ask what is the normal hemoglobin, you have to ask in what age and what sex. In newborn, the hemoglobin is very high, sometimes up to 180 grams per liter, or here in Lebanon we usually express it in grams per deciliter. So in neonates it's quite high, It decreases rather quickly during the first few months, and children tend to have a lower hemoglobin than adults. At adolescence, due to the effect of testosterone, men will have a higher hemoglobin and hematocrit than in women. These are the normal adult values. Hemoglobin, grams per deciliter, 13 to 17 in the male. In the female, it's lower. The hematocrit, again, lower in women than in men. The mean cell volume, or referred to as MCV, is very important. You have to always look at the MCV, because we tend to classify anemias according to the average size of the red cells. The normal is 80 to 95 femtoliters, or cubic micra. In microcytic anemia, the MCV is less than 80, and in macrocytic anemias, it's more than 95. The reticulocyte count, as we said, can be expressed in numbers or percentage. Here it's expressed in numbers. How do we decide if somebody is anemic? The best definition of anemia is to determine the amount of red cell mass expressed in milliliters of RBCs per kilogram of body weight. This is not easy or practical to measure. We have to sometimes do sophisticated tests with radio-labeled red cells to find out what the red cell mass is. Normally, it's not feasible to be done on regular basis. It can be done on research basis, but not routinely. So in the clinics, we look at patients' hemoglobin and hematocrit to determine if they are anemic. A reduction of hemoglobin concentration or hematocrit as percent of whole blood occupied by intact RBC, that's the hematocrit, or RBC count in a specified volume of whole blood. So if we take a fixed volume of blood, centrifuge it, if the packed volume of the red cells is 35, we say 35 of the total volume, then we say the hematocrit is 35. You have always to realize that normal range will also exclude patients that are normal, because the normal range is the mean plus or minus 2 standard deviation, which will include 95% of the normal individuals. So by definition, 2.5% of normal individuals fall below the normal limit, in the lower limit, or below the lower limit. And this is a also wide normal range. So if somebody has a hematocrit that's just below the normal, we shouldn't panic and say this patient is anemic and we have to jump and do all the tests to look out for causes of anemia. So hemoglobin, hematocrit, and RBC count are concentrations. So they will depend on so many factors. They will depend on the red cell mass and plasma volume. The value of hemoglobin, hematocrit, and RBC count decrease if RBC mass decreases or plasma volume increases. This can happen, for example, in pregnancy, where there is increase in red cell mass, but more increase in plasma volume. So the hematocrit in pregnancy tends to drop, particularly in the third trimester. If somebody is dehydrated, severe dehydration, there's loss of plasma volume, and consequently the hematocrit can go up. And if somebody loses blood acutely, they lose both red blood cells and they will lose plasma to the same ratio, and therefore somebody can be severely anemic as far as definition of red cell mass, severely anemic, he will have hypotension, he will need transfusion. But if you check the hemoglobin and hematocrit of somebody who just bled massively, you will not notice that there is a drop in the hemoglobin or hematocrit. But this patient definitely will need blood transfusion because they have lost blood mass, both blood and plasma equally. We classify, as we said before, the anemias according to the MCV into microcytic, normocytic, and macrocytic. I will not go through those types of anemias because you will hear about them later in the course. Finally, I want to emphasize to you the value of looking at the peripheral smear. The red cell morphology can change depending on different pathologic conditions. On the top left, you can see the normal red cell, which is round with a central pallor. And this is related to its biconcave shape. If the red cell becomes larger, as you see on the left side, you can say this cell is larger than the normal. You can appreciate it under the microscope, and this can occur with liver disease, alcoholism, or with megaloblastic anemias. And as you can see, I'm not going to go through all the types, but probably you should look at different types because you will hear about them later on. For example, the microcytes on the right lower side, it's microcytic cell that's small, doesn't contain much hemoglobin, and we call it microcytic hypochromic. Therefore, it's always important if you have a patient with anemia to evaluate the peripheral smear to look for any morphological changes because they can definitely give you clues as to the underlying pathophysiology. And this is the last slide, and I would like to thank you for listening and stay safe at home and have a nice spring at home.